Howdy, we are live. It is Friday night, Saturday, September 18th. It's 12:45 in the morning. I'm not sleepy. I hope you're up too. My name's Aaron Boster, and thanks for learning about MS with me. I thought I would jump online and do a live stream and ask me anything MS. Got my trusty water here, and I am ready. So I'm going to give a few moments and hope that we can amass this global growing online village. I see that Anne Marie has joined me from Cleveland. As you know, when you jump on, please tell me where you're jumping in from. Portuguese Beauty is in the house. Rainbow Star Kiss is here. Cheryl's coming in to us from the BC. That's awesome. Kelly Butler is out in California. He is out in LA. This is great. Edmonton, Alberta, Canada. Caroline, Carol, hey, what's up? TVBD, what's up? Haley, hey, how are you? I've got Bellspeak in Florida. Got a whole bunch of folks jumping on. This is really fantastic. So let me give it a few minutes for people to jump online. If you're just jumping on and you haven't done one of these with me recently, please throw your location in the chat so I know where you're calling in from. I totally love going back through these and looking where we've amassed this growing global online village. Really, really cool stuff. So we've got 46 folks online. If you guys are excited for an Ask Me Anything MS, make sure to throw a thumbs up. Let's make sure that we can get that thumbs up to go up a little bit. We have 44 folks that have joined us. I've got Deanna Martin from Gahanna. That's my hometown in Columbus, Ohio. Sydney, Australia with girly friend 4 is here. Ala from Saudi Arabia, how are you? We've got Vancouver is well represented tonight. Millie says, please say hi to me. Well, hello, Millie, how are you? Scott Anderson is in the house. There's about 55 of us. So let's give it another minute or two for folks to jump on. I've got a lot going on at the Boster Center for MS. If you haven't checked out our website recently, I'll throw that down in the chat so that you can check it out, bosterms.com. And you can kind of see what we've got cooking. A lot of research going on these days. It's really a very exciting time, bringing on a lot of new and exciting programs, which I'll be able to announce in the near term. So we've got our first question tonight, but Rachel, we're not ready to take questions yet. There's one last thing that we have to do before we can answer questions, and that's fill the whole chat with flames. So if you guys would take a moment, go ahead and fill the entire chat with flames. Let's get that thing all flamed up for me. That would be great. That'll let me know that you're ready to start doing questions, a Q&A, Ask Me Anything MS. So KCC has got the idea. We want to go ahead and get flames through the whole chat. Jane's got it going on. I just saw Girly Girl's got it going on. E is here. Okay, awesome sauce, guys. I'm digging it. You are ready. I am ready. Let's start with the questions. Make sure that your question, please, is asked in a general fashion. I can't diagnose you or I can't treat you through the interwebs, right? So I can't answer specific things about your situation. To do that, I'd have to do a consult, but I can answer more general things. This is an opportunity for education, empowerment, for education about MS and COVID and whatnot. It's not giving you medical advice. For that, you got to talk to your doctor. All right, so I've got that disclaimer out of the way, which is super important. Millie says that you rock anytime you're in town. I'd love to say, oh, that's really cool. Thank you. So Ann writes, what trials are you currently having at your center? That's a very nice question, Ann. Thank you for asking it. So we're doing 2 registries, and I love registries because I want to always be able to offer something to folks impacted by MS. Not every person with MS who wants to fight back and stick it to the disease and contribute to the body of research for MS is eligible for a clinical trial. And so there can be situations where because of a comorbid condition, let's say MS and breast cancer, God forbid, or because they're just over or under an age cutoff, someone might feel like they can't contribute because they don't qualify for a rigorous clinical trial. Excuse me. But a registry, on the other hand, is open to everybody. And so we have a registry that we're participating in for folks impacted by MS. Every single person at the center is eligible to participate. And I think that's a really cool thing. It's a really nice registry too. We're also doing an equally neat registry for neuromyelitis optica spectrum disorders. And so all of our patients at the center that have NMO are invited to participate in that. And so those are two registries that we're doing. We're also doing several phase 3 clinical trials, mostly studying BTK inhibitors. So there's a molecule called telabrutinib, and this is a BTK inhibitor that actually crosses the blood-brain barrier into the brain. And we are enrolling that trial in relapsing MS. And I think we have about 10 patients that we've enrolled into that trial. I'm really excited about that. We also have about 3 patients, I think, soon to be 4, I believe, primary progressive MS patients that are in a separate trial of telabrutinib studying the effects of BTK inhibitors in PPMS, something that I'm very excited about. Now, there's a separate clinical trial that we're doing with a different BTK inhibitor called fenebrutinib, and that is a relapsing trial also. So we have 2 relapsing trials and 1 PPMS trial. We're also doing a couple trials looking at vaccines. So we're doing a trial for people that are on Kesimpta or any of the first-line injections and how their body can receive a COVID vaccine, and a separate trial how their body receives a flu vaccine. So there's a lot of really exciting investigations going on right now. There's actually some other things that we're working on, which we think will be launching very soon. But those are the trials that are actively enrolling today. And thank you for asking that question. So let's jump into the questions here. Kimberly writes, can you explain why a 3rd dose of COVID vaccine will be more effective than the first 2? I'm confused. That's a really good question, Kimberly. Now, I did make a video on that topic recently. I think I put it out on Monday. And so if you haven't checked that video out from this past Monday, definitely go and look at that because I do talk about this. But to address it here on the channel right now, you're saying, why would a 3rd COVID vaccine be more effective than the first 2? And it's not a matter of being more or less effective. It's all about stimulating your immune system. So when you show your immune system its target through a vaccine, you stimulate your immune response to build up an arsenal against that target, so that later when you come in contact with that actual infection, the real virus, your body is prepared to pounce on it. And what we realize with some infections, like hepatitis or COVID, one vaccine is not enough to bring your antibody levels and your cellular levels up high enough to be able to effectively fight the infection. And moreover, within COVID, it turns out people are losing their immunity. So you give someone a vaccine and they mount an immunity, but some of them aren't keeping it. Or as the immunity dwindles, as your immune response to COVID dwindles, if you get infected, it can again become serious. You can get the infection. And so by giving a 3rd dose, by giving a booster, we boost that immunity back up by showing your immune system its cells again. It's not more effective, but it's effective again to maintain your cellular and your antibody immunity. So that's a good question. What do I think about boosters? I think that you should get them. So there was some information from our government today that suggested that all people over 65 and people who are immunosuppressed and healthcare providers should all get the booster. And so I'm really excited about that. I will definitely be getting it. I'll definitely be recommending that my team at the Boster Center get it. And if you're my patient, I'm very, very likely going to be recommending that we do it. So let's look at another question. Jane says, is high cholesterol common amongst MSers? So high cholesterol is common amongst humans. The most prescribed medicine, I think, in the United States is probably Lipitor, which is a cholesterol-lowering medicine. And so I think that it's maybe true, not necessarily directly related. Now, interestingly, if you have high cholesterol and you have MS, uncontrolled high cholesterol will drive your MS faster. And so that's important to make sure that you identify that if you have high cholesterol and then treat it. So ZHHS SHHD writes, is it true that Tysabri is only medium efficacy? No, that's not true. Tysabri is a very high efficacy medicine. Caroline Black writes, hey, Dr. B, I take Galatech, so that's glutaramyl acetate. I never hear you talk about it. I'm in Canada. Is this a cheaper version of a better US drug? So Caroline, howdy, and thanks for jumping on tonight. And you're taking glutaramyl acetate. So here in the United States, on brand with Teva would be Copaxone. And then there's a couple of generics in the United States. We don't have that particular generic. And I don't talk about Copaxone very much. It's a drug that I grew up using. So when I was in training, particularly in my fellowship, the men that taught me used a tremendous amount of Copaxone very early in their treatment algorithm. So they would start most patients on Copaxone. So I came up through the ranks using a lot of Copaxone. And when I was using Copaxone, this is not recently, this is a while back when I was in training, we didn't have very many medicines that were highly effective. We had Tysabri, but we really didn't understand it. We had chemo off-label, and then we had Copaxone and the interferons. And it was our belief that Copaxone was better tolerated than the interferons, and so we really liked using it. I don't start people on Copaxone any longer, and that's because I have available drugs that are more effective, in my opinion. Now, that doesn't mean that they're more effective for you as an individual human, all right? Because everybody's different. But speaking in groups, I have drugs that are superior to Copaxone. They can do a better job with brain volume. They can do a better job with disability progression. They can do a better job with new MRI lesions. They can do a better job with relapses. And so as a result, it's not a medicine that I reach for anymore. It's medicine that I used to use a lot back in the day. And thank you for asking that question. I'm going to have a sip of this water. David Yu writes, why does Ocrevus wear off after 4 to 5 months? So the biologic effect of Ocrevus, which is to deplete your adult B cells, doesn't typically go away in 4 to 5 months. And if you check your B cells, you'll see that they're still 0. But there are a minority of patients that experience this thing that people call the crap gap. And it's this seeming wearing off effect. And I've seen it in many, many patients. And I actually believe it's real. Not every patient, but plenty have it. And in those patients, I would like to be able to have the option to give them the drug every 4 or 5 months, but it's not approved for insurance as such. And so you can't get it paid for here in the United States. Can't really do that. What I end up doing oftentimes is offering a slug of steroids a month before the infusion to kind of tide them over to it. And I find that for most people, that works really, really well. Just the thing I do in my clinic. So Andrea writes, does number of oligoclonal bands matter? 5 versus 15. So I was taught no as far as making a diagnosis, but I think there's been investigations that would suggest that higher bands at time of diagnosis may have relation to prognosis. I generally think of bands, however, more along the lines of being useful in making a diagnosis. And so having the presence of bands in my mind for that is really like a yes, no, it's binary. So KCC writes, what options are you given to your Ocrevus patients that didn't produce antibodies from the COVID vaccine? So let's talk through this situation because it's a really, really frustrating and unfortunate one where one of the most effective medicines available for MS, a really great medicine that is a B cell depleter, also can result in not being able to fully mount a vaccine response to COVID. This is true for all the B cell depleters, we believe. So rituximab, Kesimpta, Ocrevus, like this question. And then also the S1P1 receptor molecules. So Gilenya, Ponvoy, Zeposia, Mayzent. And so what do you do in those situations? Well, first of all, we have to ask, is this drug controlling the MS? Because that's important. So let's take as a foregone conclusion that it's controlling the multiple sclerosis. Coming off these medicines is not straightforward. So you can't stop Gilenya cold turkey. There's a very small risk of rebound. And if you stop Ocrevus to allow the cells to come back, that can take a while. And if you've been on Ocrevus or Rituxan or Kesimpta for a period of time, they may not rebound very, very quickly. And so you could have a period where there's no B cells for quite some time. And so that's super frustrating. So what can we do? Well, one thing we can do is we can recommend you wear a mask. because that is a protection which has not gone away. It's still extremely valuable. And I actually was very happy that the mayor of Columbus, where I live, is enforcing that everyone needs to wear a mask outside and in public spaces, and that's safe. And so if you're in this situation, I would absolutely encourage you to wear a mask. That's one thing. The second thing is you want to make sure that everyone around you is vaccinated, because if everyone around you is vaccinated, it decreases the chance that you would contract COVID. Number 3, you want vaccinated. So don't say, oh, well, I'm on this drug, Zeposia, Gilenya, oh, I'm on this drug, Ocrevus, Kesimpta, therefore I can't mount a response, so I won't even bother, because that's not actually true. So first of all, you will mount a T cell response, because these medicines don't really impact, sorry, stretching here, they don't really impact T cells. But you may have a suppressed B cell response. Now, I have some patients that mount a B cell response despite taking these medicines. It's just attenuated, which leads me to my next point. I would like you to get a booster. By getting a booster, again, we increase the likelihood of pushing the immunity up. Sorry, I'm going to dim this light. Pushing the immunity up so that you can mount a meaningful response. And so there are a lot of things that we can do. Now, I have some patients and friends with MS who are seriously considering switching medicines, coming off one of the medicines that I listed onto another so that they can mount a full immunity. And I think, again, this is something that each individual has to kind of grapple with. I'm struggling with this light here. Let's see if I can flip it around. Maybe you can see me better like that. All right, let's look for some more questions, guys. So Cheryl writes, can out-of-country patients qualify for trials? So you would probably need to do the trial in your country. I don't think that you could travel out of country, in part because there are very frequent visits. So a lot of the BTK trials that I've been talking about earlier in this live stream, early on for the first 6 months or so, there's a visit like every month. And so it would be really, really hard to live from somewhere else and then fly in. Now, you could do that with, like, say, the registry or something. That might be something more feasible. But for a phase 3 clinical trial, I think it would be tough. Cheryl writes, I am 6 weeks from an infusion and wondered if it's okay to take the J&J because of a time problem. Just getting shot, losing too many friends. So I can't answer for you, Cheryl. I do think that getting vaccinated is super important, and I do like my patients to have a month after the J&J before they receive something like Ocrevus, but you would need to talk to your provider for you about the right answer. So Kyle says, link to the registry. So Kyle, it doesn't work like that. It's something that you can bring up in clinic and we can talk to you about it and we can register you there, but it's not something that you can just go online and log into. For patients at the Boster Center, you can always message us through the patient portal and let us know you're interested, and we'd be super excited about that. So Girly Friend 4 writes, besides heat, ice, or Cannabomb, what else can we try for bad hugs, intercostal spasms relief? So stretching might help, although oftentimes it doesn't. Sometimes it could. Baclofen can help. Xanaflex can help. Those are antispasmodics. Sometimes we can have some success with the anti-seizure medicines. So Tegretol or oxcarbazepine, that's trileptal. Those medicines can sometimes help. Also, you can Botox the area. So you need an expert Botoxer, someone who is a master Botoxer, because it's off-label and it's a dangerous area to be Botoxing, but there's plenty of things that one can do. There's even potentially opportunity of medicine by Edison. If it was really bad, you might be able to ask a pain doctor to put in a stimulator or something to try to help with that area. So lots that can be done. Nico writes, what is the diagnosis of MS confused with, like herpes virus or chlamydia caused MS-like lesions? So herpes virus and chlamydia are not oftentimes confused with MS. What you're really asking, Nico, is the differential diagnosis, which is doctor talk for what else could it be if it looks kind of like MS. And there's a lot of things. So there are infections that can mimic MS, and we screen for a lot of infections. There are connective tissue diseases, things like lupus that can mimic MS. There are metabolic conditions like thyroid abnormalities and vitamin deficiency sometimes that can mimic MS. There are cancers that can mimic MS. There are structural abnormalities that can mimic MS. Structural abnormalities in for example, in the spine. So part of the job of diagnosing someone with MS is proving it's not those things. And we oftentimes prove that by getting laboratories and sometimes by getting certain types of neuroimaging or chest x-rays, stuff like that. Good question. Fiona writes, how can you tell if a symptom is due to MS or other causes? Example, cramps, muscle spasms, tiredness. And you bring up a really good point, Fiona. So a human lives their life and they don't experience a symptom of MS, they just experience a thing. So if you have a spasm of your calf, you don't know necessarily why you have a spasm of the calf, you just know you have one, or a cramp or what have you. And I think the most important thing is for you to identify that there's a new symptom and to be able to describe it. What seems to trigger it, what makes it worse, what makes it better, when does it come on, how long does it last, how long has it been there, has it ever happened in the past? And bring that to your provider, that information, and say, hey, I got this new thing, what do you think? And then we can help you figure it out. And we can help try to clarify if it's likely to be from MS or something else. And we may ask you some more questions. We may do some exam things. We may do a urinalysis. We may get some blood. We may take some pictures, but we'll help you try to sort that out. I don't think it's fair to ask you, sorry, that light is really bright, to ask you to figure that out on your own. And I don't want you to do that. I want you to bring it to us so that we can help translate. All right, we've been doing this for 21 minutes. I've been doing a couple questions now for a while. If you guys are digging this Q&A, do me a favor and light up the chat with some flames again. It's really awesome to think that I turned my camera on pretty late at night and there's 116 people that have joined me. Thank you all. That's really, really cool. If you would like to continue this Q&A, go ahead and light the whole chat up with flames. Go ahead and hit that flame button, get that whole thing flamed up. Once we get it flamed up, I'll know that you are digging this and that you want some more questions. So we're getting there. I've got E helping out and Bespec, and I've got Girly Friend. Try to get the whole thing full of flames, guys. Tina is flaming it up. Still have some questions coming in. Some of you are getting the picture. We've got some flames going here from Jane and from Anne Marie. There, we did it. Vicky's helping out. Thank you, everyone. Thank you for the flames. I really appreciate it. That lets me know that you are still interested in this Q&A, and I will keep on answering questions. Thank you for the flames. Now, there's 114 of you on, and another thing that's super cool to do is to give a thumbs up. So you can jump out of the chat, hit a thumbs up, and jump back in. Of course, I'd love to get that thumbs up over 100. And so maybe we can work on that while I'm answering some questions. That would be really, really awesome. Let's jump into some questions right now. You guys were fantastic with those flames. Thank you for that. Alt Ann writes, have ever heard about drinking apple cider vinegar for leg cramps, restless leg? I have not, but that doesn't mean it doesn't work. Just not something I'm familiar with. Amal A writes, hi, doctor. I've had MS for 20 years this month. I've read that MS can become progressive with time. How do doctors change the diagnosis to progressive? So I don't really consider it a different diagnosis. I consider it a different phase of the disease. So you have a relapsing form of multiple sclerosis, presumably, and someone with a relapsing form of MS, as the disease goes forward in time, as you age, the disease can change its character, its phenotype. It can go from a predominantly disease hallmarked by attacks to a disease predominantly hallmarked by a slow progression and decline. And so I think what you may be getting at is when would we say, okay, now we're going to call this secondary progressive MS. And that's a term that I don't think is used properly. Oftentimes, I think that it has a stigma attached to it. And I would rather just be more clear with language. You have a relapsing form of MS that's manifesting progression. There are some definitions of secondary progressive MS. The one that I like is the MS-based definition, and it's kind of a complex definition with certain clinical features and certain findings on exam, but I think it's probably like the best one. What I want you to take away from my answer is that you have a relapsing form of MS, And that means that you still are at risk of having relapses. Even if you haven't had one in a while, it is possible. And you're also at risk of progression. And so the MS medicines help slow progression and they help decrease frequency of attack. And so I think that they're still very, very relevant in a so-called secondary progressive state. So 100 subscribers, please. That is a funny name. I dig it. Hey, Dr. Boster, do you know anything about, I'm not sure what that word is. I'm sorry, I'm not sure how to say that. Techno15 writes, thank you for everything, doctor. Your channel has changed my life. Oh, that's really cool in so many positive ways. Your recommendations and knowledge have given me the knowledge in order to help my current regimen. Well, that's really cool. Thank you. I love hearing that. You know, I have this channel so that I can help energize, help empower, help educate people impacted by MS. And it's really, really cool when I hear that I'm helping somebody out. So thank you for that feedback. So from New Zealand, David, let's see, writes, question. Have any of your patients who are on Ocrevus complained about leg weakness and more fatigue since starting Ocrevus? So I have hundreds of people that I follow on Ocrevus, and so I probably have experienced a lot of different symptoms. And if someone on Ocrevus has an attack affecting their legs, they could certainly have weakness. If they have progression of neurological disability, they could. And that could happen on other medicines too. Becca writes in, how long can there be between round 2 and, oh, I lost the question. I think it was, I'm going to guess that you were asking, how long can it be between round 2 and round 3 of Lemtrada? So if that wasn't the question, I'm sorry. And the answer is it can be in any amount of time. There's no rule. It can't be closer than a year, but it can be way farther away. So Techno15 writes, my question is, not many medicines have helped my nerve pain. What is your viewpoint on marijuana? And so that's a really good question. And it's an opportunity to plug the big live stream that I'm planning for this coming Wednesday. I think it's on this Wednesday. Let me double check. One momento. Yeah, Wednesday. Is that right? Yes. So Wednesday, the 22nd at 6:30 p.m. Eastern Standard Time. So 6:30 my time. I'm going to be doing a live stream focused on medical marijuana and cannabis. And I have a special guest who is an expert in the field who's going to be joining us. He's super, super awesome. He's helped hundreds of people with MS as sort of an expert of sorts. And so I'll introduce him formally and he'll be joining me. So I have a very special guest and we're going to be talking about medical marijuana and cannabis. It should be a really awesome discussion. There's going to be a very long, lively, didactic, interactive educational portion. And then we're going to do a lot of Q&A where he and I will be answering questions live. So that's going to be really cool. That's right here on this YouTube channel. That's going to occur next Wednesday. So that's September 22nd. So I hope that you can join us there. And we're going to talk about that at length. So Rachel Jane 101 writes, do you recommend a patient remain on Ocrevus after transitioning from relapsing MS to secondary progressive MS? Yes, Ocrevus has excellent data at slowing progression. Ocrevus has excellent data slowing brain volume loss. And those are things that are really important in secondary progressive MS, just like they're really important in PPMS and they're really important in relapsing MS. And so I wouldn't want to stop the medication in that situation at all. E writes, please talk more about thyroid disease mimicking MS. What tests do you do? So if you have a really high or really low thyroid, it can do a lot of weird things to your metabolism, and you can have some neurological problems, some cog fog and some other things. And so you get thyroid function tests, and you can check out the function of your thyroid and see if it's wacky. So Bluthendon writes, question, Central New Jersey. Are massages beneficial for treating MS? If so, can it be considered a medical expense? Yes and yes. And so you can ask your MS neurologist to write a script for medical massage. And you can turn that in with your taxes. You can use your FSA account for it. It can be a medical expense, yes. Some insurance companies will actually cover it. So Be Brave Warrior is doing some awesome flames. Thank you for that. Thank you, Sanjay, for the same thing. Let's see, Lynn's Dancer 1 writes, What is the infusion protocol for Tysabri? That is, are pre-meds given to stave off side effects? So there aren't any required pre-meds. Now, I used to give people Benadryl and Tylenol for a period of time. I'm not doing that anymore. I don't really find it necessary. Tysabri is remarkably well tolerated. It's been given for a long time now, having come out in 2004. And I don't really think that you need to be giving pre-meds unless the specific individual has a history where we figured out that that was the best thing for that individual person. So Anish writes, this is my first time chatting with you. Well, how do you do? And Anish writes, can I ask you anything? You can. I would encourage you to ask about MS because I don't know very much about like love or politics or sports or guns or, there's a lot of topics that I don't know much about, but MS neuroimmunology is something that I can answer questions on. So feel free to ask questions on that topic. Absolutely. JY writes, can CBD be as beneficial? Marijuana isn't legal yet here in Texas. So we don't know the answer with science because there's no clinical trial to answer that question, which is really frustrating. And the studies that have been done with CBD have also included THC, which makes it really hard to isolate. So there's almost no data. Anecdotally, I have some patients that feel that CBD helps with lots of things, but I don't have a tremendous amount of information with CBD by itself. So let's see here. Oh, so this is really cool. I've got Renino Rodriguez is from Honduras. That's super awesome. Hello. Let's see. Other questions coming through. Whoops, I just skipped around. Sorry if I lost a few. Caroline Black writes, can anesthesia cause a relapse? No, I don't think so. So people used to think a long time ago that was possible, but not really anymore. And you can go ahead and have anesthesia, and MS shouldn't really play a role. It shouldn't be a problem. Now I realize that Anish is a goofball, and so I will make him disappear. So what else do we have going on here? Let's see. Andrew Floyd writes, hi, my wife is going for hematopoietic stem cell transplant for her PPMS next week in Mexico. What are your thoughts about this? Have you spoken to anyone who has done it? So you're about to go to Mexico, which is a really big deal. I'm assuming you're going to Clinic Ruiz. And that's not something that I would recommend. In fact, I spoke to a family today, a family where the patient has PPMS, and they asked me the same question. It's not something that I can recommend in good faith. Now, that doesn't mean that you should cancel your plan or that, you made a big error, but you're asking me my opinion, and that's not what I would recommend doing at this moment. So Gluten writes, thank you, Dr. Boster. I'll be sure to ask my neurologist about writing a prescription medical massage for sure. I'm glad to hear that. That should work. Lauren writes, are foci in the brain considered lesions? So foci is a Latin word for focus, like a spot, like a particular location. And lesion is a word that means a spot. So foci and lesion to me are just words that are trying to get at the same thing. It's an area where there's been inflammation and there's been cells that are brought in and water that's brought in, and it leaves a scar. It's brain damage. And so that's what I think we should probably call it because that's what it is. All right. Question, says Paul Hatch. I've read recently that older patients are experiencing severe UTIs due to being on Ocrevus. Your thoughts? So I don't think that you can say that all people who are older have that problem because I don't think that's true. In fact, I think the vast majority of people don't have UTIs on Ocrevus. And if someone has recurrent UTIs on any drug, then we're going to look at that drug and come off. But I don't think I can say after age X or Y, that's going to happen. So Joy Tor Lassie says, OMG, I just got cupping and a massage and I feel 180% better. That's awesome. Yay, I'm really glad to hear that. Good. So I've got a message here from Burbles. Hi, Aaron. I've been watching your vids for a minute, and it's so neat to see you live streaming right now. Well, thank you. I was diagnosed a year and 3 days ago, and I appreciate, thank you. I really like knowing that this has helped you out. So that makes me feel really good. And I hope that the channel continues to help you out. All right. So Mike Delta Victor writes, can limited mobility or reduced functions be reversed by any means? So it depends why you're having limited mobility. If it's because of, and so let me be an out-of-the-box thinker when I answer this question, okay? So if you're having immobility because you had an attack and your leg is weak, we might be able to retrain it and re-strengthen it with physical therapy, right? So if you have immobility because of spasticity, we might be able to put in a baclofen pump and loosen your legs so that they can move, and then you could regain mobility. If you lost mobility because of a contracture at your across your knee or your ankle, we could have surgery to fix the contracture. And it's not prime time at all, but there are exoskeletons. So even patients that really can't move their legs with an exoskeleton can regain some degree of mobility. And that's not crazy talk. That's actually something that can happen right now. I don't think they're available through insurance, but increasingly we're seeing papers come out where we're using that kind of technology. Very, very cool. Even someone who doesn't have something like that, if they're in a wheelchair, they make standing wheelchairs where you can hit a button that stands you up. And so I don't know if that's exactly probably the kind of answer you were looking for, but hey, it's 1:22 in the morning, and I appreciate you asking the question. Just got the Pfizer booster last week, says Eleanor. How long should I wait before my next okra infusion? I'm due this month. So definitely want to talk to your doctor about what your doctor thinks is the best time to wait. If this was my patient and they got the booster, I would want to at least wait 2 weeks before I would have it, maybe even a month. Probably at least 2 weeks, probably a month. So Lisa is from Mississippi and writes, views on being JC virus positive and using Ocrevus, completely and utterly okay with me. 1,000,000%, no worries with that at all. So Radia writes, is Glutopa a good effective treatment? I do not think so. And Gary 2006 writes, question, I'm on Tysabri and I'm looked up my recent MRI and it says new mild diffusion restriction within the right thalamic lesion. What does this mean? As I was told, the repeat MRI in 3 months. Well, I haven't seen the MRI, so I can't really tell you because I don't know if I would agree when I look at the scan, if that's what I would think it looks like. So new mild diffusion restriction is something that you might see in the setting of a stroke, or you might see in the setting of an MS spot, but there's really not enough information there for me to really know. And obviously you want to call your neurologist and say, like, why are we repeating this? I think it's good they're repeating it because if they saw something abnormal, by getting a scan in 3 months, they're going to see if it's changed or evolved. And I think that's a very safe move. So ACV Mama writes, a pelvic floor therapy successful, or is pelvic floor therapy successful in helping fecal incontinence? Yes, yes, yes. So if you're listening to me right now and you're not familiar with pelvic floor physical therapy, I'm excited to tell you about it because it's freaking awesome. I was an MS neurologist for a long time before I learned about pelvic floor PT. I didn't know it existed for like the first half of my career. And it changed my life. It changed my patients' lives. Pelvic floor physical therapy is someone who's a physical therapist that does extra special training in the down theres. And they help bowel, bladder, and sexual function. My favorite pelvic floor PT is named Karina. And she would say, Aaron, make sure you tell them I get up in their business. She gets you up in stirrups. She gets up in your business. And she makes Kegels look like child's play and really figures out how to reactivate your pelvic floor. Oftentimes, you don't have to go to pelvic floor PT repeatedly. You may go once, maybe twice to retrain those muscles and learn how to reuse them. And it can make a major difference in bowel and bladder and sexual function. And I want to tell you one of my favorite stories. One of the very first times that I referred a patient to pelvic floor PT, she sent me a text message and I kept the text message as long as I could because it was awesome. And you know how text messages will fall off. I eventually lost it, but it said something to the effect of, Dr. B, thank you for referring me to Karina. I'm no longer incontinent and sex doesn't hurt anymore. But more importantly, I'm pretty certain that I could now crush beer cans with my lady parts, which I thought was awesome. So Could it help with incontinence? Yes, it can help with fecal incontinence, with bladder incontinence. It can help with sexual function. So definitely love me some PT, pelvic floor PT. Now, there's 127 of you that are online, and that's wonderful. Thank you. Let's try to get the thumbs up above 100. If you would help me do that, I would really appreciate it. It helps out the channel analytics and lets me know that you're loving what we're doing. And what are we doing? We're answering Ask Me Anything questions at 1:25 in the morning, and I am drinking water. So let's see if we can get those up. I'm actually going to grab some more water. It's my hope that when I come back, that's up to 100, and then we'll keep doing some questions. So give me a hot second while I get some more water. All right. Up to 94, 97. Let's see if we can just push it up a little tiny bit just to get it up to 100. We're at 99. I feel in my heart that we're going to do it. Come on, big money. One more thumbs up will get us to 100. And then we'll jump into some more questions. In the meantime, let's get some water going on. I'm not doing the MS water challenge because this is not a good time for people to be drinking water if they have issues with frequently getting up to pee with MS. So if I can get one, there we go. I got one more thumbs up. Thank you, everybody. Thank you. Let's jump into some more questions. Emil says, thanks for the info on pelvic PT. Never heard of it before. Possible to do the exercises at home. Once you learn them, I think you certainly can. Yes. Going backwards, looking for questions. Kathy Riggs writes, can you have MS and not have any brain lesions? I have very severe mono when I was 25. Had very dizzy spells since then, still have them almost constantly, no other medical problems. So if you don't have any lesions on your brain or spine, I don't think it's really plausible to be diagnosed with MS in the modern era. You want to make sure that you're dealing with really good scanners. So Key Avery writes, I appreciate, not appreciate, but that's fun. I appreciate your efforts, though not always in agreement. Wondering about options for spasticity neuropathy. Currently on pregabalin, so that's Lyrica. Issues with weight gain, water retention, GABA, referring to gabapentin, is also hard. Thanks. So thank you very much for appreciating my efforts. And it's okay that we don't agree with each other. I don't want people to agree with me necessarily. I want to share and I want to educate. I want to empower and I want to energize. And I give my opinion. And that doesn't make me right. It just makes me really opinionated. E writes, my doctor doesn't order follow-up MRIs because I decline immunosuppressive medicines. Is that a standard practice? No, it's not. And I think it's important to get MRIs so that you can see what's going on. Now, maybe what your doctors say is, hey, listen, if you're not going to take a medicine, why would I monitor you? Although I don't agree with that I'm just wondering if that's maybe what they're thinking. And if you told them, hey, listen, if I got an MRI that showed new stuff, that would drive me to want to change my management, that might be a robust conversation to have. Tina G writes, hi, Dr. Boster. Well, hello, Tina G. I was diagnosed 5 years ago and was working full time. I'm now walking with a cane and sometimes walker, but I have no change in my MRI. Thoughts? So I'm hearing progressive decline, and going from ambulatory without assist to a cane or walker, maybe putting your EDSS around 6 to 6.5 in 5 years is a fast progression. That's a really fast progression. And so I would want to get a hold of that and work on stuff. So Kyle Roberts asks, can I have a flu shot while on a PPMS trial? And that would depend on the PPMS trial. You definitely call the investigator and they'll be able to give you that answer. Let's see here. Other questions? Why do people with MS get ongoing non-specific pain? Says Suzanne. So MS can cause a lot of pain. When I was in med school, my professors taught me that MS did not cause pain, and they taught me that MS did not involve B cells, and they taught me that MS did not involve gray matter, and they were wrong. So MS absolutely can cause pain, no question about it. And I have an entire playlist on this channel of all the different kinds of pain that MS can cause. Now, what I imagine you're talking about is this sort of transient, intermittent neuropathic pain where the leg hurts or aches or burns, or the arm will. And this can come from damage in various parts of the brain or in the spinal cord. And it's actually very, very common that there can be sensory abnormalities in the setting of MS. So we've been doing this for 45 minutes. This is really fun, guys. Thank you so much for jumping on with me. There's 123 of you that are on right now. We've got the thumbs up above 100, and so thank you for that. Kathy Riggs writes another question. That's the same question. Sorry, I answered that before. Let's go down to the bottom and see if there's some new questions. There are. Smiley writes, hello. Can MS cause low back muscle spasm, stiffness, and pain? Absolutely. So ACV Mama writes, I wish I knew how to reply back at Caroline. Last nurse. Okay, so I'll let you guys talk. Nikos writes, thank you for these sessions. Are we close to a cure? No. So that's a frequently asked question, like, will we have a cure? And I don't think that we'll have a cure in my lifetime. Now, I would like to be wrong. I would like there to be a cure, but realistically speaking, there's so much that we don't know about the immune system still that I don't think it's realistic that we're going to stumble upon a cure yet. I think that there's a lot more that we need to know. Now, we've come a long way in our understanding of MS, like a long way, and we have more opportunities to intervene than ever before. But I don't think that we're going to see a cure in my lifetime. I do think, though, in 2021, there's something that we can do. With hard work, we can make MS boring. I have a lot of videos. I give a lot of presentations on that exact topic, how to make MS boring. And so I think that's actually a very legit goal when working with a family, is trying to make MS boring. Joining from Australia, says Leslie X. That's cool. Vanessa writes in, are they studying to find a cure? Yes. E, can you tell about your BTK trial? Patients are doing better. Now, E, the way that we do these trials is set up so that, no, I cannot tell if they're doing better. Here's the dealio. Someone decides that they would like to participate in the trial, and this is a relapsing MS trial where they're going to participate for a period of at least 3 years if they stay in the trial, and they're going to be taking medicine the whole time, but they don't know which medicine they're going to take. They're either taking Ibagio, right, teriflunomide, or they're taking the BTK inhibitor, but they don't know which one. And I don't know which one. And it's kept blinded for the entire duration of the study. The reason is, if they knew what they were on, or if I knew what they were on, it would bias our assessments. Because we would maybe think that the BTK folks should do better. So if they know they're on that, that might bias how we behave. If you're on Ibagio, maybe you might think that you wouldn't do better. And so maybe that might influence things. So it's very, very important to remain blinded. At the end of the trial, we unblind, which is really exciting. We say, oh, okay, here, turns out that for the past several years, you are on this one. And then something awesome happens, because then they offer for those patients that finish the trial to go on to BTK. So if you had been taking the BTK inhibitor, you stay on it. And if you had been on Ibagio, then you go on the BTK inhibitor, except it's open label, meaning we're not hiding it. It's no longer an experiment or a secret. They're giving it to you, and we know they're giving it to you. And that way they can continue to monitor efficacy and safety, and you have access to an awesome drug before anyone else in the world has access. Let's see here. Looking for some more questions. How do I participate in a trial? Got a really great doctor there, Vanessa. So you want to call your doctor and say, hey, what clinical trials are you involved in? Cheryl, let's see, is having a conversation there. Question, hello from Italy. Well, hello. What do you think about using modafinil for treating fatigue? I think modafinil for fatigue is awesome. I think it's a very, very effective drug. I use it all the time. Side effects are like too much coffee. So headache, insomnia, palpitations, irritability are common side effects if you have them. And you can develop a tolerance to it. So if you stay on it and never take a day off, after a couple months, it can kind of wear off. And it seems to not work very well. But if you take 1 day off a week, that normally doesn't happen. So I always encourage our patients to take 1 to 2 days off a week, or to only use it when they really need it. It's a drug that you can dose just when you wake up. Some people, they take a dose in the morning and they're good in the hood. Other people find that they need 2 doses. They take a first dose and they take a second dose before the noon hour, because if you take it after the noon hour, you're not going to sleep that night. That's a good question. Thanks for asking it. So Bluebird says, are we considered high risk where COVID boosters are concerned? So the current wording is if you're over 65 or immunosuppressed. And so if you're over 65, then you qualify. If you're on an MS medicine, not all MS medicines are immunosuppressants. Many of them have immunosuppressant qualities or are proper immunosuppressants, though. And that's a great conversation to have with your MS neurologist, because there may be things going on where they say, hey, this is definitely something that I think that you need to do. One Gone Thus writes, question, can you speak at all about non-MS autoimmune demyelination? I can. I take care of CNS inflammatory and demyelinating things. So there are some other things, but let me see, non-MS autoimmune. So, there's conditions like neuromyelitis optica spectrum disorder, anti-MOG syndrome. These are conditions that are CNS demyelinating that I also take care of. So those conditions tend to have a predilection for certain parts of the central nervous system, like just the optic nerves or just the spinal cord. And there's a different series of medicines that we use. And maybe it would be good if I did a lecture where I kind of went over those different medicines, because they've evolved of recent. So John writes, hello and thank you from Central California. Is Rituxan as effective as Ocrevus? I think it probably is, although it hasn't been studied head to head. So we can't know that. But if I was guessing, I think they're probably very similar. So ACV Mama writes, any connection between MS and OCD? Can MS cause worsen OCD? I am not aware of an increased risk of OCD in MS, but I certainly have plenty of patients that have OCD. I don't think OCD is all that uncommon. Kate Goldberg writes, whoops, I just lost, darn it. I'm so sorry, Kate. I just lost your question. That's not fair. I'm so sorry. Let's see if we can find it. Oh, there it is. Do you know anything about autologous hematopoietic stem cell transplantations for MS? Yes, I do. I've got a couple videos on this channel where I talk about that. Actually, I had a question about it just earlier this evening and in clinic today. Lemon Peel Angelfish is in. Hey, Lemon Peel Angelfish, it is great to see you from New Zealand, I believe. Writes, can you have an MS hug in the thoracic spine? Yes, you absolutely can. That's probably the most common location. All right, what else we have cooking here? We've got Ashley Becker from South Africa, a place I would love to visit. What are your thoughts on Ibagio after 60? Absolutely love it. Love it, love it, love it. I think that's a great location for Ibagio. I think using Ibagio in the second half of the disease is a wonderful place for it. Why? Because Ibagio decreases attacks, and it doesn't do it in an amazing fashion. It does it in an okay fashion, but I want you to have that. Ibagio decreases contrast, not amazingly well, but good. But what Ibagio does do really well is slow disability progression and slow brain volume loss. And those are things that are really important at age 60. And so I think it's a really great medicine exactly in that age group. I also think that it's very well tolerated and it doesn't really increase risk of infection. Another reason I like it. It's not an increasing the risk of cancer. Another reason I like it. Good drug. All right, let's see what else we have. So Radish says, why is Glutopa not effective? It's not that it's not effective. It's about 30% better than placebo. So it's effective, but it's not very effective. And what I'm saying is relative to newer drugs, there are drugs that are superior to it. So what's a good analogy? I mean, a stick is a weapon, but like a knife is a better weapon, and maybe a gun is a better weapon. Sorry, I don't want to be all violent with my example. I guess I'm just saying it's not that it's not effective. It's just that there are drugs that are way more effective. And so I want to put you on the most effective drug that you're comfortable taking. Hello, Sclerosis says, hello, and thank you for streaming. I was recently got diagnosed with MS as a 30-year-old gal. You have any advice on planning for pregnancy? Yes. Watch my video on this channel about MS and pregnancy, where I talk about it in depth. The punchline, if you will, is that it's safe to have a kid, safe to become pregnant. MS doesn't increase the risk of infertility. It doesn't increase the risk of birth defects or spontaneous abortions. And, excuse me, the pregnancy won't make MS worse. There are some discussions to be had about staying on or coming off disease-modifying therapies. But check out that video because I talk about it quite a bit, and I hope that you find it helpful. Hisham writes, I have a question. How many doctors should be examining to ensure not misdiagnosis of MS? Just before COVID hit, I was diagnosed with MS, but I want to make sure before I take the medicine. So that's actually a very good question, because if you had a really special classic car and it made a funny noise and you took it to the mechanic and the mechanic said, we have to replace your engine, the first thing you would do is get a second opinion, because that's very expensive and you might not want to do that to your special classic car. Well, your brain and your spinal cord are more valuable than any classic car. And if somebody said something as heavy as, hey, I think you have MS, it's fair. I think you're allowed to get a second opinion. But your question is a really good one. How many doctors? Because I have seen patients where they'll come to me to confirm they have MS, and I'm their 7th or 6th neuroimmunologist, and they've done a tour in the United States in some cases. And so I think if you have a second opinion, that's reasonable if you feel you need that. And I would definitely want a second opinion from someone who is an MS specialist, who that's all they do for a living, because that's all we think about. That does not mean that a general neurologist can't do a good job. They can do a great job. But if you're seeking a second opinion, I would definitely encourage you to seek that second opinion from an MS specialist. Now, we've got 56 minutes into this really fun live stream. I've had a great time. If you guys have had a great time, I wonder if we could do some more flames. It's so much fun to watch the flames come up. If this has been a great live stream, if you've enjoyed this impromptu Ask Me Anything MS experience, at 1 in the morning, go ahead and throw some flames in the chat one last time for me. Let me know that you love what I'm doing with this live stream and this Q&A. Rachel is showing some love, or Rochelle, thank you for that. Let's see if we can get some more flames in the live stream right now, guys. Can we do that? Yay, thank you, thank you. All right, let's get the whole thing flamed up. There we go. Yeah, we got it going on. Thank you, everyone. I love that. My name's Aaron Boster, and as always, I want to say thank you for learning about MS with me. I make a video on this channel every Monday morning. I've been doing that for a long time now, like years and years. And I'm going to continue to do that as long as you guys like watching them. I love when you comment on the videos. I read all the comments. I love hearing that it helped somebody or helped a family. I love when I hear that you share. And if you're listening to this and you're not subscribed to my channel, why are you not subscribed to the channel? You just listen to me for like an hour. Wouldn't you like to subscribe? That would be really awesome. I also like to do these live streams. I'm doing them once a month very formally. So my next big live stream is on medical marijuana, cannabis, and MS. That's going to occur next Wednesday. So Wednesday, 9/22. Is that right? Did I just mess that up? Hold on. Yeah, 9/22. That'll be at 6:30 Eastern Standard Time, so my time. And it's going to be a really great time. I have a very special guest that's coming on. He's going to be teaching us some really cool stuff. So until then, or until I see you at the Boster Center for MS, be safe. God bless. I'm going to try to get some sleep. Take care.